So far today, I've spent about 30 or 40 minutes talking to you about how we study simpler kind of memories in different kinds of laboratory organisms, from sea slugs up through mice. But if we ask a larger question of how we study learning and memory, one way is to look at what happens in cases where people lose their memory. Now, the loss of memory is what we refer to as amnesia. And amnesia can be roughly classified into two forms: retrograde amnesia, that's the inability to remember events prior to some sort of event or damage to your brain. And you might get this for short term if you fall and hit your head and have a concussion, not being able to remember what happened right before the accident. That's a form of retrograde amnesia. And more severe is often what we call anterograde amnesia. And that's where an injury actually damages the brain such that the individual can't form new memories going forward. So the relative position of the amnesia to the time of the injury or insult is what defines whether the impact is retrograde or anterograde. So in this context, I'm going to tell you about probably one of the most famous patients in the history of human neuroscience, and that's a patient we refer to by the initials HM. Now, HM had a procedure, a surgery on his brain that removed bilaterally most portions of his medial temporal lobe. So medial temporal meaning behind your temples. And here you can see a scan of HM's brain, and you can see he's missing large portions of his medial temporal lobe, including structures called the entorhinal cortex, part of the amygdala, and for the purposes of today's lecture, almost a complete resection of bilaterally of his hippocampus. And he did this in order to treat a very severe form of epilepsy. When he was a young man, he had a bicycle accident, and after that, he developed a very severe, almost intractable epileptic condition, and his seizures were so severe and so frequent that the doctors at the time, and this was in the early 1950s, decided to treat his condition by this invasive procedure to remove the focal areas of the brain where they thought the seizures were being generated. So you can see here, they removed his hippocampus, amygdala, and the surrounding cortical areas. Now, the good news is his epilepsy improved, but he was the last patient to receive this type of treatment. So you might ask yourself why. And that's because of the unforeseen impact on his ability to form memories. So patient HM has since passed away, roughly about a little more than 10 years ago. So we know now his name was Henry Mollison. So let me tell you a little about HM today as we wrap up this part of the lecture. So what makes him such an important patient was not that he had this very unique surgery or the impacts on his memory, but that he allowed himself very willingly for the rest of his life to be studied carefully in the laboratory to try to understand what memory abilities was affected or spared by this intervention. So after surgery, his intellect actually improved. So if you measured his IQ on a standardized test, it actually improved slightly after this surgery. His adjustment, his temperament was good, well adjusted. His perceptual and motor abilities were unaffected, no problem walking or moving. None of his senses were impaired, but he was left with very poor memory abilities. And he developed, or he exhibited both mild retrograde amnesia. So for the few years before his surgery, he had little or no memory of events in his life. But more profound was his anterograde amnesia. The time after the surgery, he basically lost the ability to form new, what we call explicit or episodic memories, the everyday memories of what's going on in his life. As I said, he allowed himself to be studied quite intensively. And one of the first psychologists to study him in depth was a woman named Brenda Milner. And this is one of her early papers on the patient. And you can see this quotation here. As far as we can tell, this man retained little, if anything, of events after his operation. She talks about how he had moved to a new house right around the time of the surgery, but he can no longer find that house. He didn't know where things were kept, and it never became familiar to him. And importantly, this forgetting he's had occurred the instant his focus of attention shifted. After extensive study by Dr. Milner, he was also studied for many years by Dr. Sue Corkin, who was a faculty at MIT. So I had met people who had worked with patient AM when I was a graduate student. And they would describe really these profound type of interactions where you met him, he seemed like a nice older man, you could have a relatively normal conversation, introduce yourself. But if you were to walk away and he was distracted and come back just a minute later, he would never remember having met you before. That was the depth or the profoundness of his amnesia. So why is he one of the most famous patients? Because he taught us a lot about memory and what systems in the brain are important for what kind of memories. Importantly, he showed that the medial temporal lobe, which includes the hippocampus, is critical for forming new memories. But also what was of great interest, it was what he could still do after this surgery. Now, we talked earlier in this lecture about how memory can be classified in many different ways. One of the simplest is how long memory lasts. We can talk about short-term or long-term memories. And there's ways to test these abilities in the laboratory. Short-term, or what we often call working memory, is something that's actively maintained. So what could he do in terms of working memory tasks? You can give very simple tasks to humans, like ask them to remember a list of 6 or 7 random digits. Someone my age, we're very used to this. We used to have to remember phone numbers prior to smartphones. And so you give someone a list of random numbers. After some break, you ask them to repeat them back to you. And HM could do this just like a control or normal individual. Another way to test this is to put different color blocks in front of the subject and have them tap the colors in specific orders. And he could do that again, just like a normal subject. So his short-term memory was relatively intact. But as Milner had quoted, his forgetting occurred the instant the patient's attention was shifted. So this constant kind of attending to this information, whether it's a sequence or the digit list, is what allowed him to express the memory of that for short periods of time. So this working or short-term memory was okay in HM, but what about long-term memory? Is it not okay? And I showed you this earlier, but long-term memory can be, again, subdivided into different forms of memory. Declarative or explicit memory, these are the memories we often think about as the daily events of our lives, things we can describe to others. And those can be episodic, like you can describe what you had for breakfast this morning, or semantic or fact-based memories, like the name of a historic individual. And on the other side are memories we can't really describe how we learned, like, your perfect tennis backhand, but you learn through repetition. So these are skills, things we call priming, I'll talk about a little more, and conditioning. And we talked about conditioning earlier in animals, and I'll show you some ways to look at conditioning in humans in the next few slides. So what about longer term memory? Well, first, they asked if he can show priming. So what is priming? It's the concept that you're more likely to use a word or complete a word if you've heard it recently. So you might go in a laboratory, and on a computer screen, words one by one get flashed to you very slowly. And so you might see a list over the course of a minute, words like puppy, mushroom, pancake, salsa, spicy. And then after some break, you can do a word completion task. And the screen shows something like this, and you've seen mushroom recently, you'll very quickly say mushroom. So if you do this task with HM, what the scientists found was that even though he had no conscious recollection of the words, if you could ask him, did you see mushroom on the screen a few minutes ago? He wouldn't remember that, but he would still complete the word mushroom at the same performance rate as a control individual. So priming was there, but the conscious or episodic component of it was missing. Interestingly, in follow-up studies, they showed that if they use words that were not commonly used prior to his surgery, so these might be words like fractal or personal computer, things that weren't around in the early 1950s, then he didn't do that as well. So it's something about having this previous experience. So what about conditioning? You can condition humans just like we can condition animals. And what's frequently used in the laboratory is Evelyn conditioning. So you have someone sit in a chair, you play a specific tone or sound, and every time you play that, you puff some air at their eyelid. That air puff makes you blink. So that's the unconditioned response to the unconditioned stimulus. And after some training, if you come back to the lab and you play the same tone, you'll instinctively blink. It's going to be the conditioned response to this previous experience. When you do this kind of conditioning in the lab with HM, again, he blinks. His performance improves across the training sessions, very similar to a control individual. But if I were to ask you, why are you blinking? You'll tell, well, yesterday you were blowing air at my eye every time I heard this tone. If you ask HM, he would not be able to describe that. He had no conscious recollection of performing it before, even though the memory was intact. So what does that tell us? So if we look across these different types of memories, we can say what is impaired and what is spared in this patient. So HM had very severe amnesia for episodic type memory. He couldn't describe the events in his life. His semantic memory, it's a little more complicated. There's not time to go into it, but it was okay. There was some impairments, but he did show some concepts of semantic memory. But over here on the procedural memory side, these non-declarative, or what we call implicit memories, these were okay. Skill learning, priming, conditioning were all still intact in this patient. So on a large scale, what did HM teach us? Well, these experiments with him supported the ideas there's many different kinds of memory. And importantly, different brain regions seem to be more important for some type of memories and less important for others. And again, I don't have time to go into this. We'll talk about this in the next part of the lecture. But the fact that his retrograde amnesia, the amnesia of the loss of memory before his surgery, was temporally graded, only went back a couple of years, tells us that after time, there's some type of consolidation process in which memory is no longer dependent on these structures in medial temporal lobe, like the hippocampus. So you might ask, why do we have multiple memory systems? Why do we need procedural and declarative systems where we can learn things in parallel? You can learn a skill, but you can also remember how you learn that skill. Well, we don't know the complete answer to this, but some of these experiments have suggested that although subjects with amnesia can perform these procedural memories, they can't transfer that memory to a new or different context. So what these systems may give us by working in parallel is better flexibility to not just learn things implicitly or procedurally, but to apply them across different experiences. So if you're interested in HM, Sue Corkin wrote an excellent review now a number of years ago. It was published 2002 in Nature Neuroscience Reviews that really lays out kind of the history of this amazing patient. And I encourage you to go back and read that. Thank you.